Before I start today's topic, let me ask a few basic questions like what is bone and how are bones formed? Okay, as basic as it might sound, bone is a form of connective tissue that forms the skeletal system of the body. And how are bones formed? By two methods. One is by enchondral ossification and second is by membranous ossification. What happens in enchondral ossification? Bone is formed from pre-existing cartilage. It forms inside the cartilage. Initially, cartilage cells are present along with its matrix that is replaced by bone by a series of changes that take place. First, a periosteum is formed that slowly lays down the bone, and then the cartilage cells die, chondrocytes die, and in those empty spaces, lacunas are formed. These spaces enlarge and some small spicules are left in between them, and those spicules form the spongy bone, which later on becomes compact bone. This is about enchondral ossification. Now what you have to remember is it is forming from cartilage and initially spongy bone is formed. Okay, and then the second type of ossification is membranous ossification. Here what happens is osteoblasts, that is the bone forming cells, invade the fibrous membrane and they form spicules of bone. These spicules will later fuse to form a lattice that can either persist as cancellous bone or later it will change into compact bone. These are the two types of bone formation. Now, why am I discussing all this in ENT? As some of you must have rightly guessed, the topic for today's video is otosclerosis or otospongiosis. And it is essential that you understand this mechanism in brief detail to understand the pathological changes that are occurring in otosclerosis. Now let us move into our topic. Otosclerosis. It is also known as otospongiosis. Why spongiosis? You will understand. So what exactly is otosclerosis or otospongiosis? The bony labyrinth that is present in the inner ear due to some reason will undergo changes and the bone will change into spongy bone. So it is called spongiosis, otospongiosis or otosclerosis. Now to understand this further, let us study about the structure of labyrinth once again. Okay. As you have learned in the anatomy of inner ear is also called as labyrinth and it consists of bony labyrinth and membranous labyrinth. Yes, able to recollect? Okay. So what is the membranous labyrinth? What all constitute the membranous labyrinth? We have the utricle, saccule, semicircular ducts, cochlear duct, endolymphatic duct and endolymphatic sac. All of these are part of membranous labyrinth, and now this membranous labyrinth is also called as otic labyrinth. Otic labyrinth and membranous labyrinth mean one and the same, and it consists of saccule, cochlea, semicircular ducts, cochlear duct, endolymphatic duct and sac. This entire chamber, as you know, is filled with endolymph. Next, the second part of labyrinth is perilymphatic labyrinth. Now this might sound slightly new. We only know about membranous labyrinth and bony labyrinth. What is this perilymphatic labyrinth or periotic labyrinth? Peri means anything that surrounds. So periotic labyrinth is surrounding the otic labyrinth. This is that compartment that surrounds the otic labyrinth. So it is that vestibule, scala tympani, scala vestibuli, and the perilymphatic space of semicircular canals and periotic duct. Periotic duct is that part which is surrounding the endolymphatic duct. Remember here in all this place, the perilymph is flowing. That is our perilymphatic labyrinth. So in simple words, it surrounds the otic labyrinth. What all are present here? We have the scala tympani, scala vestibuli, the vestibule, semicircular canals, the perilymphatic space of semicircular canals. And finally, periotic duct. All these constitute the perilymphatic labyrinth or periotic labyrinth. And finally, the third part is the bony labyrinth, also called as otic capsule. Bony labyrinth, also called as otic capsule. This is that actual bone outside the perilymph. In the perilymphatic labyrinth, what is flowing? It is the perilymph that is flowing. And outside this, that lining structure which is actually made of bone is your otic capsule. And this otic capsule again has 3 layers. What are the 3 layers? The first layer is endosteal layer. This endosteal layer is the innermost layer. Then we have the enchondral layer. Enchondral layer is that layer that is developing from cartilage. So when this cartilage is developing into bone, what happens is some islands of cartilage are still left there unossified. And sometime later on in life, they start to get activated and result in otosclerosis. Now to understand this one crucial point, we have studied all this so far. Okay? We have studied about how bones are formed and what are the layers of bony labyrinth to understand this most crucial point in the pathophysiology of otosclerosis. The enchondral layer of bone which is ossifying from cartilage by enchondral ossification, in this layer some islands of cartilages are left, and later on in life they begin to show some changes that will result in otosclerosis. Is it clear? Cartilaginous rests, islands may be present in this layer, which will later on change and show otosclerosis. And outside the enchondral layer, we have another layer, that is the periosteal layer. What is the periosteal layer? It is the outer covering. Always peri is outer covering. Periosteum surrounds the bone. Perichondrium surrounds the cartilage. And periosteal layer is the outermost layer of otic capsule. Okay? And there is just a factual point that you need to know. The bony labyrinth ossifies from 14 centers of ossification. And the first one To show the ossification center is cochlea, which develops at 16 weeks of age. 16 weeks of gestational age. And the last one is posterior semicircular canal, which shows the ossification center at 20 weeks. So in between there are 4 weeks. In these 4 weeks, all the 14 centers will develop. This fact might be important from MCQ per se, okay? So it develops from 14 centers of ossification. The first one is at cochlea and the last one is at posterior semicircular canal. We have 3 semicircular canals, right? The last one is posterior semicircular canal. And cochlea, it occurs at 16 weeks and this occurs at 20 weeks. Okay? This is a fact that can be memorized. Better to memorize, okay? Now, let us study about the etiology of otosclerosis. Unfortunately, the exact etiology is unknown. But even if the exact etiology is unknown, there will always be many theories that are trying to explain the cause for the disease. And most of them play a role in various people. Okay, let us see what are they. The first one is anatomical basis. What is anatomical basis of this disease? What we have just learnt. The cartilaginous islands that are present will show some changes. They undergo some triggers that will later result in formation of new spongy bone. And this abnormal bone, new bone that is formed, will result in otosclerosis. So that is our anatomical basis. New spongy bone formation from cartilaginous islands of the enchondral layer. Due to some trigger factors. Next in our list is hereditary and genetic factors. Why are we suspecting this? Because 50% of patients of otosclerosis have a positive family history. Most of them have another member of the family suffering from this disease or their earlier generations showing otosclerosis, which is quite significant. 50% of patients is not a small fact to be ignored. So how is this genetically transmitted? By autosomal dominant pattern. In autosomal dominant pattern, there is incomplete penetrance. Incomplete penetrance means different people show the disease in different severity. That is incomplete penetrance. And also there is variable expressivity. Variable expressivity means everybody who has the gene will not show exactly same features. That is variable expressivity. Then the third etiological factor is race. This disease is more in whites than in black Americans. And also it is common in Indians. It is common in Indians. Then, do we have some sexual predilection? Yes. The disease is more common in females than in males. Maybe the female sex hormones are playing some role because it aggravates in pregnancy. Either new cases occur in pregnancy or the existing disease becomes more severe and progresses in pregnancy. So that way, maybe there is some role with female sex hormones. Next factor is age. At what age does otosclerosis occur? It occurs between 20 to 30 years. That age, the patient starts to show features of hearing loss. A decade before and a decade later are also possible. That is 10 to 20 and 30 to 40 also some people will present. But it's very, very rare before the age of 10 and after the age of 40. So 20 to 30 years, this is the age group. Next, there are some other trigger factors. What are the trigger factors? I have already told you one in females, that is pregnancy. The disease may start in pregnancy or it might get aggravated. Next is menopause. Some major accident or a major surgery. These are all certain significant events after which otosclerosis may start. I am telling this because sometimes patients will give you this typical history that I was absolutely normal and then I underwent some surgery somewhere else in the body, and from then on in the post-op period I started experiencing hearing loss. Now generally what we feel is there is no relation between the surgery that he underwent and this hearing loss. One factor that we might think is, did he use any ototoxic drugs? When there are no ototoxic drugs, we find no clue between this hearing loss and that event. But the patient will strongly tell that there is a correlation. In that time, otosclerosis has to come into your mind because it can get triggered by an accident or by a surgery, by pregnancy and all these factors. Okay? And also there is one special mention that you have to know about, and that is osteogenesis imperfecta. Now I am sure all of you know about osteogenesis imperfecta. It is a disease, it's an orthopedic disease involving bones. Type 1 collagen is affected in osteogenesis imperfecta, and at the baby stage itself there will be multiple fractures. The healing of fractures is normal, but the patient experiences multiple fractures and it's quite a serious disease. Okay, that's osteogenesis imperfecta. Now, osteogenesis imperfecta plus blue sclera plus this otosclerotic changes and conductive hearing loss can exist together. And three of them form a triad which is called as Van der Hoef syndrome. What is Van der Hoef syndrome? It's a triad of osteogenesis imperfecta plus blue sclera plus otosclerotic changes. Now this is important because in about 50% of patients of osteogenesis imperfecta, we find otosclerosis at some stage in their life. Okay. So osteogenesis imperfecta is observed very much early in life. During the first 1 year itself, we identify the case to be osteogenesis imperfecta, whereas otosclerosis occurs later on in life. So when you find a patient of osteogenesis imperfecta, it is essential that we keep otosclerosis in mind and follow up the patient for otosclerotic changes later on. Okay. And another important factor is, when you observe the histology of these two diseases, it is the same features that are seen. This type 1 collagen is affected in both of these diseases and they are histologically very, very similar. So it's important that you understand this relationship. Next, let us look into the pathophysiology a bit in detail. Let us understand the pathophysiology of otosclerosis or otospongiosis. First is listen to me like a story and then you can write down the flowchart. So otosclerosis is a localized, irregularly progressive disease that primarily involves the otic and labyrinthine capsule of the temporal bone. And in the otic capsule also, the most important area is around the stapes footplate, the footplate and the region around it. Okay, and it is irregularly progressive. Then the main feature of this disease is replacement of the normal enchondral bone by spongy vascular bone. Now, how does this happen? It happens in various steps. The first indication of this disease is enlargement of the perivascular space. It's a potential MCQ. The very first indication of otosclerosis is enlargement of perivascular spaces. Then what happens is the existing bone that is present first, that has to be removed. How can bone be removed? By osteoclastic cells. So osteoclastic cells will get activated and they will cause bone resorption. And then new bone is formed by osteoblasts. In this change, what is happening is, normally you might say in every bone of the body this occurs. Bone is constantly getting remodeled, isn't it? Osteoclast is absorbing and osteoblasts are forming new bone cells. This process is normal physiological. But it is not physiological in the otic capsule. Please remember, this process of bone remodeling is physiological in all other bones of the body, but not in otic capsule. Any of these changes, if it occurs in otic capsule, it is pathological. Okay. So, new bone is formed by osteoblasts. And then we see osteocytes, and the osteocytes that are found in the advancing edge of the lesion will extend to the otic capsule by finger-like projections. So that's how the small focus is getting enlarged. The osteocytes that are present at the margins will keep on extending and the lesion will enlarge in size. And this lesion will contain vascular spaces in the center. Then it is said to be in active process, active stage. The final result, what will happen is, there is disorganized bone that is rich in osteocytes with enlarged marrow spaces, and these marrow spaces are rich with blood vessels and connective tissue with joint cells, osteoblasts, and finally there is a disorganized structure. What do we want in the bone? The bone is known for its strength. We want compact bone and not this type of spongy bone that is disorganized, rich in marrow spaces and rich in joint cells. This is not what we want. But unfortunately, this is being formed and that will result in the entire havoc that is about to follow. This process of resorption and replacement of bone is what essentially is otosclerosis. Then as the disease advances, what will happen is the focus from the site, from the beginning point, will gradually involve the entire oval window and it will cause fixation of stapes. Now, while studying about various types of hearing loss, you must have definitely heard of this term, fixation of stapes. Why will stapes get fixed? Normally, the three ossicles of middle ear are quite mobile. Only if they are mobile, they can transmit the sound waves. And suddenly, why is the stapes getting fixed? It is because of otosclerosis. The stapes footplate will initially get fixed and gradually the entire bone will get fixed. And in later stages, these osteosclerotic changes not only involve the oval window but they spread to the round window and they go into the cochlea also. And the disease is expanding. And finally, there comes an inactive stage where these marrow spaces are again replaced by bone. Dense bone is formed, but even then it is not in the normal physiological way that is supposed to happen. There are a few areas of dense bone, a few areas of spongy bone. Finally, it's a complete disorganized structure that is not functional. Okay, so this is about the pathophysiology of otosclerosis. Now, you might write down this in the form of a flowchart very briefly. So, to begin with, there is some etiological factor that acts as a trigger. etiological factor that acts as a trigger for all these changes to happen. And these will affect the otic capsule. What exactly is happening? There is enlargement of perivascular space. Enlargement of perivascular space. This is the first indication of otosclerosis, the first change that is observed. Then what happens is bone resorption occurs by osteoclastic cells. Bone resorption by osteoclastic cells. And then those cartilaginous islands were present, right? The unossified cartilaginous rests or islands, they will form new bone. New bone formation occurs, and this new bone that is formed is not dense and compact, but it is spongy. Spongy bone is formed that is rich in vascular spaces and giant cells and osteocytes and osteoblasts. Then what happens is the lesion increases in size. The lesion undergoes expansion, and if it involves the cochlea, if it goes inside into the bony labyrinth, we call it cochlear otosclerosis. If it involves the footplate of Stapes, we call it stapedial otosclerosis. And sometimes it can involve the round window also. There is no particular name for that. But these are the three things that can happen, and out of which stapedial otosclerosis is very, very important. Okay. Next, let us look into the appearance of otosclerosis. Grossly, if you look at an otosclerotic lesion, it appears grey, white or yellow and chalky in color. It has a chalky appearance, that is grey white or yellow in color. This is the gross appearance. Initially the footplate, later on even other parts around it can get involved. And histological appearance, if we see, it depends upon the stage of the disease. It could be, the disease could be in active stage or in inactive stage. During active stage, what we see is the spongy bone structure. What is there in spongy bone? Immature osseous tissue with large marrow spaces, giant cells, osteoclasts, osteoblasts, and mainly numerous vascular channels are present, and this will give a blue color appearance. They are called blue mantles. Another feature that we see in the active immature stages, there is a lot of cementum, and this cementum is responsible for giving the blue color. Next, let us move on to inactive stage. The inactive state of disease is actually the mature, progressed state. Here we find that this spongy bone is almost replaced by solid, compact and lamellar bone. So here we find solid, compact bone. Even the marrow spaces are reduced, and there is a mosaic-like tissue where there are only tiny marrow spaces and some very few blood vessels. And all the cementum is also replaced by fibrillar tissue. And this inactive lesion has red colored appearance. This is about histological features of otosclerosis. Then, depending upon the amount of otosclerotic bone deposition in the region of footplates, it is divided into 4 types. Let me describe those. Depending upon the area of involvement, the amount of otosclerotic changes, it is divided into 4 types. In type 1, less than half of the footplate is involved. Less than half of the footplate. In type 2, more than half of the footplate is involved. There is thickening of the footplate. Now in type 3, what we observe is the whole footplate is involved and it appears to be thick, but the margin of the footplate is still normal. Whole footplate is thickened except the margin. The margin can still be identified. In type 4, what happens is otosclerotic bone is deposited in the entire footplate and even the oval window is obliterated. That is type 4. The entire footplate is involved in otosclerotic changes, obliterating the oval window. Now let us look into the types of otosclerosis. What are the types of otosclerosis? As I have already told you, the changes that occur in the footplate of Stapes are most important around the oval window. So we have 3 types, and the first among them is stapedial otosclerosis. This is the most common variety. This variety causes fixation of Stapes, and when Stapes is fixed, what type of hearing loss will it result in? Stapes is very much a part of the conductive pathway, so this results in conductive type of hearing loss. So stapedial otosclerosis is the most common variety, and this results in fixation of Stapes footplate. Fixation of Stapes footplate. And in this stapedial otosclerosis also, we have 5 sub-varieties depending upon where the lesion is starting. And let us see all of them. This is the first one, and that is called as anterior focus. This is the most predilected site for the development of otosclerosis, and it is also called as fistula antifenestrum. It lies in front of the oval window, and this is the anterior focus. Next we have what is known as posterior focus. This is behind the oval window, it is starting. I hope you are getting the orientation right. The middle ear ossicles, we first have the malleus, incus and stapes. Stapes is directed this way with the foot plate closing the inner ear, and the two cruri of stapes are present like this, like a bell. And then the third type is circumferential type, where the disease spreads around the margin, leaving the center. This is the circumferential type. It is all around the stapes footplate, but the center is spared. Then we have the biscuit type, which is the opposite of circumferential type, I can say, because the entire footplate is involved but the margin is spared. It is not exactly the margin of the footplate, it is the annular ligament that is spared and it is free of disease. So you can see the entire center, the entire footplate actually, not just the center, but this annular ligament is free of disease. And finally, we have the obliterative type, wherein the disease process will completely obliterate the oval window, and that is seen here. Neither the margin nor the center is spared here. Completely the oval window is obliterated. This is the obliterative type. So these are the 5 types of stapedial otosclerosis. Let us see. Cochlear type of otosclerosis. This type of otosclerosis involves the region of round window and areas of bony labyrinth and the petrous part of temporal bone. So the cochlear part is directly affected and not the stapes part. So what type of hearing loss does this result in? It causes sensory neural type of hearing loss, which is irreversible. And it is because of the disease process, one thing. And second is, this otosclerosis will release some toxic materials which travel via the fluids of inner ear and they also damage the cochlea. The inner ear fluids are disturbed. And this is how it causes irreversible type of sensory neural hearing loss. The cochlear otosclerosis involves bony labyrinth and this results in sensory neural type of hearing loss. And this causes sensory neural type of hearing loss. And the important feature is the toxic materials of otosclerosis can inner ear fluids and result in irreversible type of hearing loss. And finally, we have the third variety, that is histological otosclerosis. After stapedial and cochlear otosclerosis, we have histological otosclerosis. What is that? Here, only histological changes are observed. How do we diagnose the disease? When histology is done. Otherwise, the patient remains asymptomatic. There is neither conductive nor sensory neural type of hearing loss. Although the changes of otosclerosis are occurring, there are no features. The patient is asymptomatic. Only histological features are observed. This is histological type of otosclerosis. With this, we completed learning about the etiology, pathophysiology and types of otosclerosis, both stapedial, cochlear and histological types, and also the types depending upon the area of involvement. Type 1 less than 50%, type 2 more than 50%, type 3 the entire footplate is involved except the margin, and in type 4 finally the entire oval window is obliterated. So we have learnt about all the types, histological and gross appearance also we have learnt. And next we have to learn about the clinical features and management, which we shall do in the next video. So thank you for now.